You're on your first day working in the operating room, and the attending physician asks you to get out an ampule of local anesthetic. You open the drawer and you're faced with a myriad of different drugs with different concentrations. This particular tutorial will look at the different drugs that we use to provide local anesthesia, the concentrations of those drugs, the dosage of those drugs, including the maximum dosage, and also the type of additives that people put into local anesthetics in the belief that those additives will alter the pharmacology. I guarantee you'll learn something. Anesthesiology tutorials with me, your host, Pat Nelligan. Local Anesthetics, Part 2, Drugs, Concentrations and Strategy. Welcome back. If you have survived the previous tutorial, and perhaps you had to watch it a couple of times, congratulations, this one will be easier. In the previous tutorial, we looked at the basic pharmacology of local anesthetics, and I explained that they are weak bases. They are partially ionized at physiologic pH. The pKa determines the degree of ionization, and unionized particles enter the neurons more rapidly. That means that the lower the pKa, the faster the onset and offset of action. Protein binding acts as a reservoir for local anesthetic. The higher the protein binding, in general, the longer the duration of the block. Finally, lipid solubility determines the potency of the drug. Higher lipid solubility means greater potency. In this tutorial, I will discuss concentrations of local anesthetics versus activity, different local anesthetics that are available and when to use them, additives to local anesthetics, and the maximum safe dose of local anesthetic. Let's start with local anesthetic concentration. You're in the operating room. It's your first day as an anesthesiology resident, and you're asked to draw up 3 ml of bupivacaine for a spinal anesthetic. When you open the drawer, you are confronted by an intimidating array of different local anesthetic drugs. You asked for clarification and are told to get some bupivacaine out. You will find 3 different concoctions: 0.25% bupivacaine, 0.5% bupivacaine, and something called heavy bupivacaine, 0.5%. What's in these ampules? Although these 2 ampules look identical, if you read the labels carefully, you will see that these are the 2 major concentrations of bupivacaine and levobupivacaine. On the right, there is 0.25% bupivacaine. That seems like a very small number, and it is. It's 1/4 gram of bupivacaine in 100 ml of water, or 250 milligrams per 100 ml, and that works out at 2.5 milligrams per ml. On the left-hand side, there is 0.5% bupivacaine, that's twice the strength, 0.5 gram per 100 ml, or 500 milligrams in 100 ml, or 5 milligrams per ml. Bupivacaine comes in many different forms. The 0.25, the 0.5, there's one called 0.5% heavy that I'll explain later on, as I will for 0.25 with epinephrine and 0.5 with epinephrine. The other major local anesthetic that we use is known by 2 different names. It's always been known as lidocaine in North America, a name based on its chemical structure. However, in the UK and Ireland and so-called Commonwealth countries, it was known as lignocaine. The decision to rename lignocaine to lidocaine was driven by the adoption of the International Non-Proprietary Names Organization. That's a system established by the World Health Organization to standardize drug names globally. Lidocaine is now the universally accepted name for this particular agent, so stop the G if you're still using it. Incidentally, epinephrine is the INN name for adrenaline, but where I work, adoption has been a little bit slower for that particular agent. There are 2 different concentrations for lidocaine that are commonly used for intravenous or subcutaneous injection. and they are 2% lidocaine, that's 2 grams, 2,000 milligrams in 100 mils, 20 milligrams per mil, or 1% lidocaine, 1 gram in 100 mils, or 10 milligrams per mil. You will immediately notice that the ampule of bupivacaine 0.5% contains 5 milligrams per mil, and 2% lidocaine is 20 milligrams per mil, and that is not by accident. These are considered equipotent concentrations. In other words, bupivacaine is 4 times as potent as lidocaine. The other version of lidocaine that you may encounter is this one. It's a liquid. It's topical lidocaine. It's used in our practice for doing fiber optic intubations, and it's 4% or 4 grams per 100 mils or 40 milligrams per mil. I make a point of mentioning this because doctors, anesthesiologists frequently forget the topical dose of the drug that they give when they give further doses subsequently intravenously or subcutaneously. Now you want to do a spinal anesthetic. Which concentration of bupivacaine should you use? 0.5% or 0.25%? There is a difference. When you're trying to block a thinly protected structure like a delta pain fiber, even low concentration local anesthetic is very effective at penetrating the outer wall. But alpha motor neurons are very thick and robust, and the same drug dosage may not be sufficient to penetrate the structure sufficiently to provide loss of motor function and surgical anesthesia. So you need that higher 0.5% concentration of, for example, bupivacaine when surgical anesthesia is required, such as a spinal anesthetic or regional nerve blockade, such as upper limb blocks for the forearm, wrist, or hand surgery. The choice of local anesthetic agent determines the onset of the block and potentially the offset. If, for example, you're having dental surgery, you want that block to work very quickly and wear off quickly. You don't want a numb face for the rest of the day. Conversely, if you're having shoulder surgery, perhaps you'd like to have a numb shoulder so that you can get a night's sleep after the operation. The volume of local anesthetic determines the duration of the block. The higher the volume, the longer the block is likely to work. It also determines the effectiveness if you're not carefully targeting the nerves, for example, by ultrasound. If you spray enough local anesthetic in and around the nerve, you're probably going to block it. The concentration of the local anesthetic determines the depth of the block. Let me explain. I have 3 different nerve fibers. The thinnest are the pain fibers, then slightly thicker are proprioceptive fibers, and finally we have very thick alpha motor neurons. In some situations, we want to give a patient a pure sensory nerve block to kill pain. An example of this is an epidural that's used for postoperative pain or for labor and delivery. In that situation, we're going to give our patient a continuous infusion of low concentration local anesthetic like 0.125% bupivacaine. This concentration is usually not high enough to impact either motor function or proprioception. A higher dose of local, for example, 0.25% bupivacaine given in modest doses will wipe out pain and probably wipe out proprioception, but will have limited impact on motor neurons unless a large volume is administered. In situations where absolute anesthesia is required, we will use full-strength 0.5% bupivacaine, and that will remove all sensation, motor, sensory, and autonomic. An example of such a situation is spinal anesthesia, where a very fine needle is passed into the subarachnoid space. We do this for cesarean section, hip or knee arthroplasty, and various lower abdominal and lower limb surgeries. A modest dose of 0.5% bupivacaine injected into this space will provide absolute anesthesia, motor sensory and autonomic, required at the level of the surgery and a couple of dermatomes above that. The standard local anesthetic is 0.5%, 2 to 3.5 mils injected at the level of the lower lumbar vertebrae. I want to perform a nerve block. Should I inject 10 mils of 0.5% bupivacaine or 20 mils of 0.25% bupivacaine or levobupivacaine? Why are you performing the block? Is it for surgical anesthesia or is it for pure analgesia? If it's for surgical anesthesia, you need a short-acting, dense motor and sensory block. So you're going to use concentrated local anesthetic. If it's very short-acting, 2% lidocaine, and for intermediate-acting, 0.5% bupivacaine or ropivacaine 0.75. For analgesia, if you're performing a field block, an epidural, an iliacus block, a tap block, or a rectus sheath block, then a large volume sensory block is required. We're going to use dilute local anesthesia, such as 0.1% bupivacaine up to 0.25% bupivacaine or levobupivacaine. Or if you need to do a selective nerve block purely for analgesia, such as a brachial plexus block or an ankle block, low to moderate volumes of local anesthetic are required. In that situation where you're independently picking off nerves, we're going to use concentrated local anesthetic, 0.375% bupivacaine, 0.5% bupivacaine, or 0.75% ropivacaine. To summarize, when you're looking at concentrated versus dilute local anesthetics, we have to look at what we're doing it for. The dilute anesthetics are used principally for analgesia. If you want anesthesia, you've got to use concentrated drug. The concentrated drug is given in low volumes. It's dose limited because of toxicity. The dilute drug is used in high volumes. The onset of action with the concentrated drug is faster, the duration of action of the concentrated drug is longer, and the depth of block is denser. Just to mention, the higher the volume administered of either concentrated or dilute local anesthetic, the more rapid the onset of the block, the more likely that the block will work, and the longer the duration of the block. On the downside, there is increased risk of local anesthetic toxicity. An excessively prolonged block, for example, pressure injury, may occur due to insensate areas with slower rehabilitation. Patient, for example, can't walk after their operation. Regardless, it's often very difficult to predict block offset. Let's move on and talk about the newer local anesthetic agents from the 1990s. In advance, it's important to point out that there are no local anesthetics of longer duration that are better than bupivacaine. It remains the best overall local anesthetic, but it has significant problems with potential toxicity. Ropivacaine, and that's this particular drug, 7.5 milligrams per mil, that's a 10 mil ampule, goes by the trade name Narapin, was developed in the 1990s. And it was developed specifically as a way of sparing motor neurons with a relatively dense sensory block. So it is purported to be motor sparing in situations where you don't want a motor block. For example, with an epidural, you want the mother to be able to push the baby out. The reason for that is because it's slightly less lipophilic than bupivacaine. It also has a shorter duration of action versus bupivacaine and a significantly lower toxic potential. Bupivacaine is 1.5 times as potent as ropivacaine. It's equipotent with levobupivacaine that I'll talk about in a minute. If I administer 20 mils of ropivacaine, 0.75%, what is the equivalent dose of bupivacaine, 0.5%? Think about that for a second. The equivalent dose is 20 milliliters or 100 milligrams versus 150 milligrams in 20 mils of ropivacaine. If I administer 20 ml of 0.25% bupivacaine, what is the equivalent dose of 0.375% ropivacaine? Again, the equivalent dose is 20 ml or 75 milligrams of ropivacaine versus 50 milligrams of bupivacaine. This is Levobupivacaine. It's also known as Prilocaine. And what is good about this particular agent is that it is dosed exactly the same as bupivacaine and can be administered in any situation that you would use bupivacaine. It comes in ampules that contain 2.5 milligrams per ml, 0.25%, 5 milligrams per ml, 0.05%, and 7.5 milligrams per ml, 0.75%. We no longer have 0.75% bupivacaine because it's considered too dangerous. But levobupivacaine is considered a safer drug, and that's the main reason why you might use this drug. Bupivacaine, when injected in large volume, has a high degree of potential central nervous system and in particular cardiovascular system toxicity. It's a racemic mixture that contains equal parts of two mirror image isomers, or-bupivacaine and s-bupivacaine, otherwise known as levobupivacaine. The or enantiomer is considered to be more cardiotoxic, so levobupivacaine was developed to be a safer drug with similar pharmacological properties to the racemic mixture. Now, it's not identical. There is higher protein binding for this particular agent and a lower affinity, thankfully, for cardiac sodium channels. If you look at the relative pharmacology, with its or enantiomer and lower protein binding, bupivacaine has a more rapid onset of action and a longer duration of action. This may, for example, make l-bupivacaine a better option for day-case spinal anesthesia, although there are shorter duration options such as Prilocaine or, if available, chloroprocaine. So far, I have mostly talked about local anesthetics that come in bottles or ampules. To give an infusion, you need to either draw up the local anesthetic in a big bag of fluid or purchase a product that is pre-diluted. In most hospitals these days, you can find these pre-diluted bags. This is one of them. It's Ropivacaine, 2 milligrams per mil. That's 400 milligrams and 200 mils, or 0.2%. In our hospital, we have two other bags. One is Levobupivacaine, 0.125%. That's 250 milligrams in 200 mils. Yes, this is in Spanish. That is a supply chain issue. And another version that contains fentanyl, 2 micrograms per mil. That's used for epidural analgesia. Although these doses are not exactly equipotent, they are used interchangeably in clinical practice. I think it can be very confusing as a newcomer to anesthesiology to figure out what local anesthetic to give when, because everybody has their own opinions and their own favorites. One thing I will point out is that I really don't like diluting up bags of local anesthetic, so whatever's on the shelf is what I'm going to use. This is what seems to be the case for most of us in the hospital I work in. For spinal anesthesia, in general, we use 0.5% bupivacaine, usually the heavy version, without anything else in it except for maybe fentanyl or morphine. The rationale for this is that it just works. For field blocks, where we are looking for a long analgesic duration, so this is a rectasheet block, a tap block, or equivalent, we will use either 0.25% levobupivacaine or 0.375% ropivacaine. For epidural infusions, levobupivacaine 0.125%, usually with fentanyl, is used. The alternative is ropivacaine 0.2% with fentanyl. For dense blocks, levobupivacaine 0.5% or ropivacaine 0.75%. This is the higher potency, and if you're looking for motor sparing, you will choose ropivacaine over levobupivacaine. For paravertebral catheters or rectasheet blocks, again, ropivacaine 0.2% or levobupivacaine 0.125%. If you're looking for early mobility, then Ropivacaine is more motor sparing. But again, everybody has their own opinions. Prilocaine is an agent that's been around for a long time, but it's not used as much as it used to be used, but I see a small resurgence of its use now. You will see it as a topical local anesthetic in the eutectic mixture of local anesthesia, and that's used for children to, for example, numb the back of their hands as a mixture of Prilocaine and lidocaine. A gel is put on the hand and it numbs the skin. It was also traditionally used for Beer's blocks, that's intravenous regional anesthesia. It has a similar onset of action versus lidocaine with a 25% longer duration of action. There is very low risk for systemic toxicity, but a slight risk of developing methemoglobinemia. When can it be used? Well, for dental anesthesia, infiltration and nerve block for routine dental procedures, for regional infiltration, peripheral nerve blocks, and even spinals, where it has an intermediate effect. So if you have a pretty fast surgeon and you're doing day case operations, Prilocaine is a really good option for spinals that wear off relatively quickly. For IV regional anesthesia, as I've mentioned, for Beer's blocks, to me it is the best agent. It's used for topical anesthesia, as I've mentioned, and is a good choice for short day case procedures. Versus lidocaine, and this is a very fussy table, the big difference is that it has a slightly longer duration of block. One of the things you might notice here is the protein binding is lower with Prilocaine versus lidocaine. And you will remember that I told you that protein binding influenced the duration of the block, but Prilocaine seems to last a bit longer, but it's less protein bound than lidocaine, and I do think you should know why this is. Lidocaine is slightly more lipid soluble than Prilocaine, and so it enters the cell more quickly and wears off more quickly. It's also a mild vasodilator. Prilocaine has minimal effect on vascular tone. It tends to hang around. But because lidocaine is a vasodilator, it becomes redistributed away from the tissues more quickly. So the amount of lidocaine at the site where you've injected it is relatively lower than the amount of Prilocaine because of the increase in the blood flow, and that results in more rapid clearance. The duration of action of a local anesthetic, yes, is influenced by protein binding, but there are a lot of other variables involved. Some of those variables may involve the inclusion of additives to the local anesthetic that may help prolong the block. You are about to suture a patient's arm in the emergency room and you request a local anesthetic. You are offered this. This is 2% lidocaine with 1 in 200,000 epinephrine. What is this? Well, let's start with the lidocaine. That's 2 grams in 100 mils, 2,000 milligrams in 100 mils, or 20 milligrams per mil. So that is concentrated lidocaine. And that's what you want to give very quick onset, dense blockade of that area that you're going to be suturing. What about this 1 in 200,000 epinephrine? What is this? Well, this is a drug ratio, and it's a bit of an anachronism. It's an old idea that has hung around for many decades longer than it should. Drug ratios are a way of expressing the strength of a solution. A 1 in 1,000 ratio for epinephrine, adrenaline, is 1 gram of epinephrine in 1 liter of solution, and that works out at 1 milligram per mil. A 1 in 10,000 ratio for epinephrine is 1 gram of epinephrine in 10 liters of solution, or 0.1 milligram per mil. In our ampule of local anesthetic that contains epinephrine, the ratio is 1 in 200,000. That is 1 gram of epinephrine in 200 liters, or 0.005 milligrams per mil, or 5 micrograms per per mil. This is a 10 ml syringe or 1 in 10,000 concentration. This is the mini jet that we use during cardiac arrest. So what is in this amp? 1 in 10,000 is 0.1 milligram per mil. The syringe contains 10 mils. 10 mils of 0.1 milligram is 1 milligram. A lot of the preparations of epinephrine contain 1 milligram. The most common one that you'll see is a single 1 ml ampule that contains 1 milligram, 1 in 1,000. So this ampule contains a mixture of drugs. It contains 2% lidocaine and 1 in 200,000 epinephrine. That works out at 20 milligrams per mil of lidocaine and 5 micrograms per mil of epinephrine. Why add epinephrine to local anesthetic? The first reason is that it prolongs the duration of the block. Epinephrine causes local vasoconstriction, and that reduces blood flow at the injection site. It slows absorption of, for example, lidocaine or bupivacaine into the bloodstream, allowing it to remain at the area of injection longer, thus extending its anesthetic effect. The second reason is that by giving epinephrine, you reduce the risk of systemic toxicity because by slowing the rate at which lidocaine or bupivacaine enters the systemic circulation, epinephrine lowers the risk of toxic effects in the heart and the central nervous system, allowing for the use of higher doses of these drugs safely. The third reason is the vasoconstrictive effect of the epinephrine also minimizes bleeding in the operative field if you have injected local into the area. For example, plastic surgeons do this all the time. And this is particularly useful in procedures where a clear bloodless area is desired. And finally, as a diagnostic aid in epidural anesthesia or analgesia, the presence of epinephrine in the test dose can help detect the presence of, and finally, as a diagnostic aid in epidural anesthesia, the presence of epinephrine in the test dose can help detect accidental intravascular injection. It will cause a rapid increase in heart rate and blood pressure if injected into a blood vessel. As an anesthesiologist, most of the time you will use regular ampules of lidocaine for your intravenous or subcutaneous injections. Occasionally, you will use the multi-dose bottle with epinephrine. This is principally used to reduce bleeding and prolong the block, and it is more likely to be used, for example, by plastic surgeons who are doing operations under local anesthesia. The bottle of bupivacaine with epinephrine is really only used by surgeons. Again, the principal reason for using this combination is to provide local anesthesia in a bloodless field. That's because the epinephrine acts as a vasoconstrictor. The choice of bupivacaine over lidocaine is for prolonged duration of the block. Most of the time as anesthesiologists, we don't want a prolonged block with bupivacaine, and if we do want a longer block, we will use Levobupivacaine or Ropivacaine. Most anesthesiologists avoid this particular product. The reason is that it contains 2 preservatives. Methylparaben, that's an antimicrobial, and metabisulfite, a stabilizing agent. We are concerned that these may be neurotoxic. So multi-dose vials of bupivacaine or lidocaine are not used for spinal, epidural, or caudal anesthesia. Let's move on to dexamethasone. Many anesthesiologists add dexamethasone into their local anesthetic while doing blocks in the belief that dexamethasone prolongs the duration of the block. It reduces the dose required to achieve a block. It accelerates the onset of the sensory block, and it may reduce the requirement for rescue analgesia. The mechanism of action is unclear. Perhaps it has an anti-inflammatory effect or an anti-edema effect. Anesthesiologists not infrequently mix long and short-acting local anesthetics. This is very popular because the mixture of, say, 2% lidocaine with ropivacaine would be expected to speed up the onset of action of a block. And if you're doing a block on a patient, for example, for arm surgery, and you're not able to sedate the patient, you want to make sure that the block is fully working before the surgeons start operating. That lidocaine is combined with either ropivacaine or bupivacaine or l-bupivacaine, which has a longer duration of action. So we have two things. We're going to have a faster onset of action of the block for a long case, and then the block should stay working for a prolonged period of time and help the patient get through the postoperative period and require less post-op analgesia. It does work, but unfortunately the mixture hasn't got a huge impact on the onset of the block. Usually there's quite a delay between the block being done and the surgery starting anyway, and it significantly shortens the duration of the block. I don't do this in my clinical practice, but many do. The other question about the spinal anesthetic that we started with earlier on is that you're asked to give the patient 3 mL of heavy bupivacaine in the spinal. What is heavy bupivacaine and how does it work? Well, the word heavy refers to hyperbaric bupivacaine. Dextrose is added to make it denser than CSF. The drug sinks downwards. This is believed to result in a denser block, controlled spread, less hypotension, and a lower risk for high spinals. It is the standard agent that's used for spinal anesthesia, particularly for cesarean section. Other things may be added to spinal that include fentanyl, morphine, or clonidine, and all of those are also used to prolong the duration of the block, as does epinephrine. So let's briefly look at the various drugs that are added to local anesthetics to enhance the quality of the block. The first drugs are vasoconstrictors, as I've mentioned. Epinephrine prolongs the duration of anesthesia and reduces systemic absorption and thus toxicity. Sodium bicarbonate, the carbonation of the local anesthetic, reduces injection pain, speeds up the onset of action by increasing the non-ionized form, and reduces intracellular pH because of the carbon dioxide that goes into the cell, increasing ionization and effect within the neuron. Opioids like fentanyl, sufentanil, or morphine improve the quality and duration of neuraxial, that is spinal or epidural blocks, reducing the required volume of local anesthetic. Alpha-2 adrenoceptor agonists like clonidine or dexamethasone prolong the duration of the block and may have other analgesic effects. Corticosteroids such as dexamethasone extends the duration of the block. Ketamine, which is only occasionally used, may enhance the analgesic effect. And hyaluronidase is used in retrobulbar eye blocks to facilitate the spread of the anesthetic. Now let's look at the maximum safe dose of local anesthetics. Local anesthetics are sodium channel blockers. All nerve action potentials work by activation of sodium channels, so local anesthetics that enter the bloodstream may block sodium channels in the brain, the respiratory system, and the heart, particularly the cardiac conduction system. Whenever you do a block, a certain amount of local always enters the bloodstream, and it's eventually cleared by the liver and kidneys. One hopes that the release of the local from the tissues is slow, but release it does, and sometimes faster than one would want. So it's imperative that all doctors who inject local anesthetics know exactly the quantity of each agent that one can inject into the tissues that remains relatively safe. Note, though, that I am not referring to direct intravenous injection. Even small quantities of concentrated, highly lipophilic local injected intravenously can have a devastating impact. One proviso: intravenous lidocaine has been used in a controlled manner quite safely for decades in pain management and in the treatment of ventricular arrhythmias. I approached this topic with some trepidation for a number of reasons. I'm going to give you the numbers that you must know for exams, you must know for clinical practice, but there are problems with this approach. Textbooks and clinical practice guidelines list the maximum safe doses of local anesthetic. However, they don't account for all the routes, all the sites of injection, and the risk of intravascular injection. They assume normal physiology, normal body composition, and normal organs. They likely underestimate the toxic dose in some settings and absolutely overestimate the dose in others. So this is a public health warning. What follows is what's in all the textbooks, and it provides practice guidelines for clinicians. However, it does not reflect true real-world experience of toxicity. If you're an anesthesiologist, you need to know these numbers, and you will be asked them. But I will point out that the maximum safe dose is not where we see toxicity most of the time. Most of the time we see toxicity from local anesthesia is when it's injected intravenously accidentally at modest doses. Nevertheless, I believe that you need to be extremely careful with the volume and concentration of drug that you give. So here are the numbers. The maximum safe dose is usually listed in milligrams per kilo, and even this is a problem. Is that the actual body weight, the predicted body weight, or the lean body weight? Clearly, the safest but likely excessively conservative number is the lean body weight. The penetration of adipose tissue with local anesthetics is relatively low, so actual body weight in obese patients will likely overdose the patient. So one is much better off using an adjusted body weight for drugs such as bupivacaine, although you could probably dose lidocaine at actual body weight because of its greater distribution. The maximum dose of lidocaine is 4.5 milligrams per kilo. The maximum dose of bupivacaine is 2 milligrams per kilo, but this can be increased by adding epinephrine into the bupivacaine. The maximum dose of levobupivacaine is 2.5 milligrams per kilo. For ropivacaine, it's 3 milligrams per kilo, and for prilocaine, it's 6 milligrams per kilo. You need to know these numbers. However, there is a bit of a problem because there is a strange anomaly here. On the surface, it looks like you can give a larger dose of ropivacaine to levobupivacaine, but we previously discussed that levobupivacaine is 1.5 times as potent as ropivacaine. The maximum safe dose of levobupivacaine is 2.5 milligrams per kilo, but the maximum safe dose of ropivacaine is 3 milligrams per kilo. According to this, the levobupivacaine is actually safer than ropivacaine because it's 1.5 times as potent, but only 1.2 times as toxic. So if you have a 90 kilogram male, such as George, undergoing major surgery, and you're planning on performing abdominal wall blocks using, for example, 0.25% levobupivacaine, the maximum safe dose is 2.5 milligrams per kilo. The maximum safe volume, well, that's really easy because of the numbers, is 90 mils. But if you're going to use ropivacaine, 0.375% or 3 milligrams per kilo, and you can work this out, the maximum safe dose using these numbers is only 72 mils. So that's substantially lower volume than you would give with levobupivacaine, and that is not what happens in the real world. Nobody believes that ropivacaine is more toxic than levobupivacaine, and there's a good reason for this. These numbers are misleading. Ropivacaine has a wider therapeutic window than levobupivacaine. It requires a higher plasma concentration to induce both cardiovascular and CNS toxicity. This is known as the cardiovascular collapse versus CNS ratio. I'll talk about that in the next tutorial, but just remember the numbers. For ropivacaine, it's 4.3. That's high. That makes it really safe, versus 2.6 for levobupivacaine, which is low, which makes it quite dangerous. It's less lipid soluble, so it is less likely to bind to cardiac and CNS tissue. It causes less sodium channel blockade in cardiac tissue. And realistically, we don't know for sure what the toxic dose of modern local anesthetics are. These numbers are extrapolated from animal models and case reports. To do research on humans to induce cardiac arrest would be completely unethical. So be careful of the dogma and tyranny of practice guidelines. They are maximum safe doses, not absolute toxicity thresholds. They err on the side of caution, but there are a number of risk factors that you must take into account for your patients. Intravascular injections will rapidly raise plasma levels and cause sudden toxicity even in modest doses. You need to be careful at highly vascular sites such as the intercostal space or anything that abuts a major blood vessel, for example, the femoral artery or a brachial plexus block in the supraclavicular area just beside the subclavian vein. Patients' weight, their kidney function, liver function, where they have cardiac disease, that affects their clearance, so drugs will accumulate. You also need to be careful if boluses of the drugs are being repeatedly performed. This often happens with epidurals that aren't working very well. And then, of course, you need to think about lipid solubility and protein binding. Every patient is different. Every nerve block is different. Assess your choice and volume of local anesthetic on a case-by-case basis. And above all, whenever you insert a needle into a patient, always draw back and ensure that the needle is not in a blood vessel before injecting. Finally, you're in the operating room and you have performed a nerve block for the major component of the operation, but there is a second site that you haven't blocked. The surgeon asks, can I give local? Which drug and what concentration? First up, this is good clinical practice. Surgeons must never give local anesthetic without first informing the anesthesiologist. Moreover, if they're adding epinephrine to the local anesthetic, you need to know this as well. This is the standard of care everywhere, no exceptions. In general, try to keep things simple. They should use the same drug as you gave into the block so that the cumulative dose can be calculated. So if you use 0.25% Levobupivacaine, they should either administer that dose or 0.5% and calculate the cumulative dose. It is a little bit of a problem if they want to give epinephrine. So if the patients had Levobupivacaine, I suggest that they use bupivacaine with epinephrine. Let's review this tutorial. In this tutorial, I discussed the impact of concentration on local anesthetic agents versus onset of action and depth of block. We looked at the different types of local anesthetics, the agents that are added to local anesthetics to improve their function, and the maximum safe doses of local anesthetics. In the next tutorial, I'm going to discuss one of the scariest things that any anesthesiologist will ever experience, and that's local anesthetic systemic toxicity, or LAST. I'm going to discuss the history of LAST from cocaine to bupivacaine and the treatment of local anesthetic systemic toxicity if it happens to you while you're doing a nerve block or you're in the operating room. I'll see you then, and I guarantee you'll learn something. That's the end of this second tutorial on local anesthetics. Next time, we're going to look at what happens when it all goes wrong, local anesthetic systemic toxicity. If you're enjoying the tutorials, please subscribe to this channel. Mention me to a few of your friends, leave me some likes and some comments. I'll see you soon.